the nurses found for education a teach-back tool to be quite useful. One of the nurses mentioned asking the patient questions such as like, what will you do when you have a fever? Tell me what you do. And what do you understand from what the doctor just told you? And so that was just kind of a way that they could go back and forth with the educational process and really understand what the patients understood.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS. Today we are joined by ONS member Beth Faiman, an advanced practice provider at Cleveland Clinic in Ohio, to discuss how to address knowledge gaps and barriers to practice in patients who are preparing for or who have received CAR T-cell therapy for hematologic malignancies. Beth is here to share the findings from 2 ONS focus groups on the topic in March 2023. The group specifically discussed the transitions of care during the phases of CAR T-cell therapy, barriers and challenges, and how best to support patients, caregivers, and the care team. This podcast episode is produced by ONS and supported by funding from Janssen Oncology and Legend Biotech. ONS is solely responsible for the criteria, objectives, content, quality, and scientific integrity of its programs and publications. Thank you for joining me today, Beth.
Thank you for having me.
Let's start with the first discussion point from the focus group, access to care. Can you briefly explain the current landscape of barriers to accessing care for patients with hematologic malignancies who are going to receive CAR T-cell therapy?
That's such an interesting question, and thank you for asking. There are several barriers to access to CAR T-cell therapy. First, I'd like to just super briefly go over what multiple myeloma is to set the stage for those of you that are listening that might not have full awareness of the cancer type that we're talking about. So multiple myeloma is a disorder of the clonal bone marrow plasma cells, and these plasma cells are responsible for producing these immunoglobulins that are intended to protect one from various conditions such as infections and inflammation. Through a series of genetic changes and cellular alterations, the plasma cells become malignant. Now, these cancerous plasma cells will cause damage to one's bones and cause some, we call it CRAB criteria, so it's hypercalcemia, renal insufficiency, anemia, and bone damage. And since we have all these new cool drugs available, fortunately, patients are living longer than ever. Now, in the last decade especially, the BCMA therapy has emerged as a major target of the tumor necrosis factor or TNF superfamily. So BCMA is expressed on late memory B cells that are committed to plasma cell differentiation and express more often than cancerous plasma cells than the healthy cells. There are several mechanisms of action of BCMA, and the cool thing about the CAR T-cell therapy is that we take one zone T cells, we re-engineer them with what we call a CAR or chimeric antigen receptor that targets this BCMA, and we're kind of programming the cells to be natural fighters. And I explain it to patients as that we take their own cells, we make them into fighters, and then they circulate in the bloodstream so they have this ongoing killing. Now, you had asked about the barriers to the CAR T-cell therapy. So not only is this only currently available to patients who have 4 prior lines of therapy, the drugs were approved, again, the 2 CAR T-cell therapies that were approved in the FDA in 2021 was idacaptogene viclucel or ide-cel, and in 2022 we have ciltacabtagene autoleucel or cilta-cel. What was captured in the focus group and very evident in talking to the nurse navigators especially was that use of these therapies in clinical practice has remained limited, mostly due to supply chain issues, kind of the layover of the COVID that really impacted the manufacturing of these CARs. I wrote an article in the Transplant and Cellular Therapy Journal in 2022 April that expressed the challenges we had in getting our patients in for the CAR T-cell therapy because each institution got about 1 to 2 slots depending on the product. And that limited availability demanded that we prioritize our patients in a way. And we had to balance these clinical factors and strike the balance of who should get the treatment or not. So I think that now, fortunately, we are having a lot more availability with these therapies. The manufacturers are giving almost like a lottery system so that you can go into the portal and sometimes grab an extra slot for your patients. And I'm pleased to report that in my center, we had a waiting list of over 80 patients at any given time. Now that list is down to 5, which is super great for our patients.
That is really cool and so nice to see it is so much more accessible. What were some of the other ways that some of those healthcare facilities were helping mitigate some of the other barriers that might have come up?
Yeah, absolutely. The navigators and coordinators reported finding funding from different benefactors, help with finding and obtaining insurance. For example, maybe they lived in an area that didn't have CAR T-cell because CAR T-cell therapy is not available everywhere. It's only at certain centers. So even if you do transplant and cellular therapy at a large major hospital, you still might not have access to that CAR T-cell therapy. So again, the nurse navigators and coordinators helped with finding and obtaining assistance, affordable housing for caregivers, because you have to stay close to that site for sometimes up to 30 days, depending on the institution. And also we used tumor boards, again, to discuss the different availability of patients for clinical trials and, of course, access to clinical trials as well. So those logistical challenges were very evident to the CAR T-cell slots of the participants. And again, what I also heard was the acuity of the patients. So because patients were waiting for the slot, we saw in some research that about 25% of patients would pass away while on a waiting list, and they were mostly on the waiting list greater than 6 months. Again, that problem is hopefully a thing of the past in multiple myeloma, but the nurse navigators were very aware of those challenges, and it led to the sickest of the sick patients who this was their last opportunity for a CAR T-cell. And so the acuity of the patients, I heard from nurse navigators, were a little bit challenging. And then you also had to wait for the manufacturing. So when we go through the apheresis process after the patient's selected for this therapy, then there's a period of time from 4 to 8 weeks. And these heavily pretreated, very sick patients where they have to keep their cancer in remission before they can actually get their cells back. And so all of these things, including the physical barriers, really played into challenges for the nurse navigators, which they worked really hard to overcome.
Sounds a lot like the very early days of bone marrow transplant with patients waiting for those treatments and not knowing when they're going to be able to move forward with them.
Yeah, absolutely. So it's very similar to bone marrow transplant. So when we are having the discussion about whether or not patients are a candidate for these therapies, sometimes I do compare it to transplant because they have to be hospitalized in many cases. And I think we'll talk later on about cytokine release syndrome and some of the other side effects that are short-term and long-term, but they have to be hospitalized. They have to have their cells collected by a central catheter through the apheresis process. So there are a lot of similarities in the stem cell transplant process that patients can resonate with that helps them feel a little bit more comfortable. But we still are manufacturing and altering these cells to make them fighters so that they can do what they need to do and kill the cancer.
Thanks. After the decision is made to proceed with CAR T-cell therapy as a treatment option, the first step is the workup and consultation phase and then preparing for leukapheresis. There's a lot of information and planning involved in this, and I know a lot of times that can be very overwhelming. During the focus group, what were some of the methods discussed on how people could support patients during this period?
So just like with anything we do in oncology, there is a lot of education that is required. So the same navigators that take care of our patients through the transplant and cellular therapy process, like the autologous stem cell transplant, we have similar cellular coordinators that were part of the focus group. So these navigators actually started the discussion after they were selected as the therapy. Now they might have gotten various levels of information from the healthcare provider, like the doctor or the nurse practitioner, but really the navigators were critical to start the education and provide effective resources that were reinforced throughout the treatment. I heard some words like giving binders and packets and handouts, and then videos as well. They acknowledged, however, there was an element of information overload from time to time that was a concern. but they did provide those patient education binders, calendars, dedicated chemo classes, and other educational materials in a variety of languages that were found to be helpful.
That's excellent. And I know a lot of times when those binders are there or other ways, standard therapy, then the nurses, when they follow up with patients later, they can say, I know you've already seen this or heard this, but let's go back to it again.
Yeah, absolutely.
Were there any challenges identified when coordinating care for patients as they transition through those phases of care?
Yeah, absolutely. The nurses and coordinators play a huge role during the transition of care. Not only do they help with coordinating appointments, but the scheduling of tests and coordinating with the referring team. I heard a lot in the focus group about the nurses communicating from inpatient to outpatient and also coordinating from center to center. So as I mentioned earlier, not every center that provides cellular therapy like transplant can do CAR T cell therapy. So there's that discussion in the back and forth that some of the nurse navigators had to have. Now, oftentimes it fell on the shoulders of the provider, such as the physician or nurse practitioner, but there was often handoff and coordination that was used there. There was some information overload on behalf of the patients I heard about and the nurses. But again, providing a calendar of dates and those follow-up phone calls by the navigators and coordinators really helped minimize that nervousness and information overload. Also, we heard the nurses express that they understand the education support was continuous throughout the journey. So just as you mentioned, if they provide the binder and calendars, and you can say, hey, you might have seen this before, but here we're going to go over it again. That can continue to reinforce and stress the very important care management strategies, because when patients have the CAR T cell, there's short-term and long-term side effects they need to be aware of. And it's really the nurses that provide that education.
Exactly. One of the topics discussed during the focus group was the challenge of infusing CAR T cell products, remembering all the specific requirements for each of the different products. What were some of the measures taken to support the nurses in that?
Some of the approved therapies and indications were discussed in the support group. And as we talked about, the nurses provide education on behalf of the nurse specialists. They really looked to ONS was one of those resources that were highly cited for the up-to-date education for their teams. They also discussed that they had some homegrown or resources that they created for themselves or their nurses. I heard things such as grids for the different products and requirements for each, such as the points of administration, like what kind of filter, do you use a filter, do you not use a filter, how long do you infuse it over? And then there's also resource binders with product information and resource pages on individual internet sites. So it seems like the infrastructure and most of the nurse navigators in their centers, they were pretty knowledgeable and had some quite comprehensive information for the other nurses. Some of the things I heard too is because the nurses would float from unit to unit. You have to really provide that education so that somebody that doesn't work there full time knows what special things to look at for those patients that are receiving CAR T cell therapy in the hospital, and then also those patients in the outpatient that are getting like blood transfusions or antibiotics or fluids.
Thank you. After the infusion of CAR T cells, a big portion of the nurse's responsibility is to assess for and manage any acute side effects that may arise. What are some of the more common toxicities associated with CAR T cell therapy?
Well, I wish I had an hour to go over all of the indications and things to look for nurses. I'm fortunate to be integral in the assessment and intervention of these side effects. And again, it starts with education. It starts with the nurse navigators going to ONS for resources or the product websites. And again, there's this thing called a REMS program. It's called a Risk Evaluation or Mitigation Strategy, or REMS. And that is set forth by the manufacturer. That is a very strategic way of saying, okay, when patients get the CAR T cell therapy, we know that cytokine release syndrome, which occurs when the patients are given their cells back, that can go about 7 days after for cell-to-cell therapy, or 1 day is the average onset for ide-cel therapy. So we know that these can happen, and there's a very strict criteria and education of the nurses. But at any rate, the T cell therapy does require close monitoring. We heard about how nurse navigators help secure housing and other financial assistance during that time. They have to be staying close to the T cell center. but it does require monitoring. And we do about 30 days of monitoring for most patients. And that's to identify for the short-term side effects that are very serious, such as the cytokine release syndrome, and the longer-term side effects that can be the immune effector cell-associated neurotoxicity syndrome. And the monitoring involves conducting physical exams, tracking body temperature, vital signs, regular blood work, blood counts, chemistry. Serum ferritin levels can be a sign of an acute phase reaction or some signs that this will be emerging. And LDH levels are another blood test that are obtained. The healthcare providers will also do some routine testing. So there's an ICE tool, the immune cell effector therapy tool, and it's asking things such as, can you write your name in cursive? Can you count backwards from 100 by tens? And those changes will be a sign that there are change in maybe this ICANS or CRS. So we're oftentimes asking the caregivers, they have to have a caregiver for 30 days. They can't drive for 30 days. We're oftentimes asking the caregivers to do these things if it's before they're admitted to the hospital, depending on the institution. So the nurse navigators have a lot of education, not only with the patient, but the partnership with the patient and the caregiver. And a caregiver, just like with transplant, is essential to them actually getting this therapy.
I know I remember hearing a caregiver at one point in time say when we were teaching them to hook up to IV fluids and monitor for these acute toxicities. This is not what I signed up for to be a caregiver. I am not a nurse. But it's exactly what we're asking of them.
For sure.
Are there any standard protocols or guidelines to manage the toxicities, the ICANS or the CRS that you mentioned?
Yeah, absolutely. As I alluded to just briefly earlier, we have the cytokine release syndrome. There are different grades. Grade 1 is where somebody spikes a fever of greater than 100.4 Fahrenheit. And I would tell you what, it was 38 something Celsius. Well, we're just talking Fahrenheit these days, I guess. But if they spike a fever of 100.4 or greater, but they have no oxygen needs and they're feeling okay, then that's considered a grade 1. Now, at that point, most institutions will give a drug called tocilizumab. Tocilizumab is an anti-IL-6, which will block that process of the cytokine release syndrome. We want to prevent it from getting to grade 2. Some institutions wait till they have a little bit of oxygen requirement or a little bit sicker, but many institutions these days will jump in with the toci early on. As it progresses to stage 3 and 4, that is more serious, and patients will land in the ICU sometimes. So there are standard measurement tools and grading scales for that. And I also kind of went over the ICE, the immune cell effector therapy tool by Lee and colleagues. That is a validated tool that nurses will use, and it varies per institution. Every 8 or 12 hours, that will be the tool to look for neurotoxicity. Now, you can get CRS by itself, or you could get ICANS by itself, or you can get them both together. And so you have to educate the nurses and the caregivers and the patients that both of these can happen. The ASTCT has guidelines on toxicity management. Otherwise, you want to look for blood cultures and work them up for a sepsis because these patients are immunocompromised. But again, it mostly is that CRS or ICANS, and it's limited and it's reversible. So patients can get really nervous when they're feeling sick. I explain it to them like you know how you get a flu shot and you might have a little reaction as we're training your immune system to provide immunity. Well, it's like that, but way worse. So you can get really sick feeling and achy from this. And so that psychosocial support is super important too. Again, if there are some guidance from the manufacturer, guidance from the REMS program, but most institutions have developed their standard order sets and their standard ways of doing things. So again, the patients are educated, the nursing staff is educated, caregivers, and again, the severity varies per individual.
I love that analogy of the flu shot because that's pretty much what it looks like, right?
Yes, exactly. It's just way worse.
Exactly, way worse.
Patients don't understand, you try to do all you can as a nurse navigator and an educator to explain to them, we just don't know how sick you'll get. You could get a little sick or a lot sick. I've seen people fly through and do great with these therapies, but then you get other individuals have a little bit more challenges with the side effects, and you just do the best you can as a nurse to support them through.
Exactly. So we know some of these patients might receive their CAR T-cell infusions in the outpatient department, and this requires a lot of help from the patients and caregivers to monitor, and you already mentioned some of that. With the discussion in the focus group, was there any suggestions on how to improve patient safety?
Yes, it's actually nowadays we're getting a lot more comfortable with certain of products. As I mentioned, the Cilta-Cel, which is the FDA approved product from last year, 2022, the average onset of the cytokine release syndrome is day 7. So it makes sense to give the product as an outpatient and then educate the patient and the caregiver for side effects and symptoms of the CRS and the ICANS. Some nurses did discuss within the focus group that their facility has standardized pathways for the advanced practice providers to call the patient, like maybe around 10 p.m., assess them before nighttime, and then they have dedicated on-call providers that reinforce education of the patient and caregiver before they leave clinic every day. So lots of different strategies for these patients with this unique concern. And again, similar to what we discussed, the severity depends on the intervention by nurse and staff assessment. So if they don't have a fever, it's like 99, but they're really feeling okay. They don't meet the cutoff. So you just have to really watch them. And it takes a lot of burden on the patient, caregiver, and the nurse to be really astute to those symptoms and intervene. We do provide wallet cards to patients. We educate the emergency department staff. I heard a lot about that from the focus group. We also heard about the infection monitoring, and caregiver support is absolutely critical. Fortunately, the symptom management has become quite standardized, the participants reported, which really affords the nurses more autonomy to intervene more efficiently to stop the process of the CRS or the ICANS before it escalates.
So after the patient has been reinfused and they've kind of gotten over like that initial bump that first week or so, you're continuing to follow them for disease surveillance, managing any of their long-term side effects. And then many patients are then referred back to their primary oncologist. What are some of the challenges that you all identified during this phase, and what were identified as ways to support both the patients and their primary oncologist that they're referring back to?
So the focus group included nurses that were primarily inpatient. We had some outpatient nurses, and then the nurse navigators. So we had a nice mix of the different perspectives. And in most of the respondents had said that the patients were generally managed by the cellular therapy team and kept close by for the first 30 days, maybe seen twice a week, especially if they were kept outpatient until day 30. And then they were seen once a week by day 60, and then they could go to see their provider another day that week. One nurse also mentioned the local providers like to ask a little bit more for direction if something comes up. But by the 6-month period, patients tend to be almost entirely back to their home office or their local area. Because remember, the CAR T centers are oftentimes a large referral center. Not everybody conducts the CAR T. So patients are sometimes driving 2, 3, 6+ hours one way to see them. Again, when academic centers transition back to care to a local facility, there's a process that's oftentimes followed, such as informing the providers exactly what to look for, testing timelines, who's checking the labs, who's making sure that their patients are in remission and making sure they're not relapsing. And so there really has to be that partnership between the community-based hospitals and the academic centers. That handoff is critical. And we know it's the nurse navigators and coordinators who do work closely with that referring team to ensure that the follow-up plan is communicated. And again, that timeline of what to expect is really important to reinforce. One of the things that was also mentioned was that patients should have access to their patient portal so they can see their labs come in and communicate their labs. And sometimes you could schedule virtual health visits for those that live far away and or have challenges with transportation. So there are many different ways you can coordinate care. I think before the pandemic, care coordination looked a lot different. Now, patients, caregivers, nurses, and hospitals are a lot more comfortable with the virtual aspect of care. And I think that's the one huge benefit that came out of the pandemic, if I might say.
I 100% agree that that was the one shining star that came out of the pandemic, was that it made healthcare more accessible for so many of our patients, and especially with patients who were being treated at academic centers and, as you said, live 6-8 hours away. It's decreased the number of visits that they've had to make, which has been huge.
Right.
All right. So one of the other areas that was discussed in the focus group was about education of the patient and the caregiver. How do the different institutions that were represented in the focus group approach patient education? You talked a little bit about it earlier, but were there any big other shining stars that came out of it?
Yes. So a significant portion of the focus groups were addressed on resources for the patients and the caregivers. Providing resources for these groups was of utmost importance. Some people use the Leukemia Lymphoma Society. They found that the website had items that could be printed and given to the patients and used by all, as well as binders distributed by their own academic institutions who perform CAR Ts. Because again, a lot of the institutions had to create their own materials, and that was from that REMS program. But they found what helped and worked for them and what worked for the nurses on the floor. Some academic centers did use the manufacturer's materials, but some also noted that they can't use branded materials in their center and instead often referred patients to the company's website. So it's not like they weren't using the manufacturer website, they just couldn't advocate and have printed materials in their area. But the nurses also agreed, however, that product-specific resources were very helpful. Some of the manufacturers often had provided some educational materials, thermometers, and journals. And so that was just like kind of a side note. So that's something that we observed. And then the nurses found for education a teach-back tool to be quite useful. One of the nurses mentioned asking the patient questions such as like, what will you do when you have a fever? Tell me what you do. And what do you understand from what the doctor just told you? And so that was just kind of a way that they could go back and forth with the educational process and really understand what the patients understood. The one thing that I did hear is that nurses mentioned that there were a lack of resources in multiple language with CAR T, and they would like to see a little bit more patient education resources on toxicity in different languages. But overall, CAR T and myeloma is still kind of new, and so I could see that coming down the road.
Definitely. What were some of the challenges identified when educating those patients and caregivers?
I just mentioned the language barrier, and that's a huge barrier because we also know through research that there are gaps in care among patients that are Black and English is not a primary language. And we try so hard as nurses to bridge those gaps and not let those patients be left out or feel left out. But unfortunately, that's still a reality, is that patients aren't getting necessarily all the quality information they need. So fortunately, we have translators that can be on the phone these days, so they can call in and then translate discussions in the patient's native language, which is always very helpful. From an educational standpoint, for patients that were non-disparate or just in general, during the transition of care, some of the nurses kept referring to the calendars. But one of the comments I think I remember hearing is that if there's a side effect or toxicity or a hospitalization, then that calendar has to be redrawn. So that might be a little bit frustrating if you have your calendar and all the appointments made and patients know when they're going and coming, and then all of a sudden something happens. You have to make a new calendar and make new appointments. Therefore, the patient portals were a very helpful tool to keep track of those appointments and be able to be advocates for their own transitions, not only just within the institution, but when they go back to community. There was also reported sections in their patient binders about financial resources, important phone numbers to call, such as the financial office, social workers, and then transition back to the healthcare provider. Some institutions actually reported that they have in-person or virtual training that they require patients and caregivers to attend when treatment started, not only necessarily, just chemotherapy in general, but with the CAR T-cell therapies specifically.
Excellent. We've talked a little bit or a lot about education of the healthcare team. Are there other specifics that you would like to mention about educating nurses, those coordinators, navigators, the emergency department, any of those areas?
Yeah, I think we did speak quite a bit of it. What I heard from some of the navigators, the nurse navigators, is that several institutions do have standard operating procedure manuals that really help. You get it all approved by Nursing Has a Voice, the physicians, pharmacy, and that really outlines the education that's required. In some of the institutions, they recorded the education for CAR T cell monitoring and then allowed the nurses to play it back at their own convenience. Maybe you're a night shift working nurse and you couldn't view that education. We talked about the risk evaluation and mitigation strategy. And then there's also preceptorship. So not only were some of the resources located in the hospitals and the internet, but one nurse mentioned they had a preceptorship which required 2 infusions of the product with bedside education and an opportunity to manage side effects before they could be fully independent. Some centers have annual competencies for cellular therapy, annual skills days, or other checklists that need to be maintained in order to stay proficient. Training is also aimed at intensive care unit nurses, because if you think about that patient with cytokine release syndrome or ICANS that lands themselves into the intensive care unit, what does that ICU nurse or the emergency staff or the rapid response teams, what do they need to know in order to take good care of the patients? And then finally, I think the nurses that were part of the focus group indicated they could use continuing education contact hours in cellular therapies, which might be difficult to find and be a gap that we could close perhaps, but specific courses for CAR T-cell therapy would be nice and beneficial in their opinion.
I know those can be very important too for those people who are looking to keep up their BMTCN as it evolves and includes more cellular therapy information required in that. Were there any other gaps in resources for the healthcare team identified?
So one participant did say it would be helpful if there were more streamlined process among the different CAR T-cell therapy products. So during today, I've been mostly focusing on multiple myeloma, but don't forget there's other products out there for lymphoma, CD19-directed products, and it can get quite confusing for the nurses that are caring for these patients. Say, okay, does this patient have diffuse large B-cell lymphoma, or do they have multiple myeloma? How do I administer this product? And so that goes back to the standardization in many of these institutions. Fortunately, I mean, these have to all be approved centers, and they're very carefully regulated by many different processes. And so, yes, each manufacturer has different packaging requirements, system logins, passwords, timing, and safety practices. But again, the nurses overall are able to keep track of all the nuances, but it can be very challenging. They would like to have probably one place to go where they can log in and access many CAR T-cell products. I'm not sure that's a possibility, but anything can be possible, right?
From the nurses' ears to the manufacturers, right?
Yes.
I have just a couple more brief questions to follow up on, and then we can wrap up. What are some common misconceptions about CAR T-cell therapy?
So CAR T-cell therapy is so new that there are some misconceptions that need to be dispelled, I think, or myths that need to be dispelled. There are differences between the lymphoma products and leukemia products and the multiple myeloma products. I think right now the misconception with the myeloma products is that it's salvage. I think that comes from the approval that's 4th-line therapy. You can't access it. The FDA-approved indication is later lines of therapy. I will say, though, there was a paper that was published in March of 2023 with a research study that randomized one of the CAR T-cell therapy against 5 different standard of care. And this paper that was published in the New England Journal of Medicine says, well, maybe we're going to be moving these therapies early on because there was some real favorable response to that therapy. The other product, again, I don't want to use specific product names, but the other CAR T-cell product has a similar study with results that will be reported at the European Hematology Association meeting in 2023 June that also shows that this is a very favorable product that could be moved early on in therapy. So right now, the idea that this is a salvage therapy is kind of a myth. If I have anything that I can advise the nurses who are listening is refer your patients early and often. Not only could they have access to clinical trials that might be looking at these therapies earlier than later, but just getting on the list, getting comfortable with that institution and building that relationship between the CAR T-cell center and the community center, I think is really important.
I think that's a very excellent point. And to your point about it being not a salvage therapy, but after having received previous therapies, the same thing was true with the lymphoma products, and they have now been moved much further up in the pipeline as far as when they're accessible by the patient.
Right.
Is there anything else about CAR T-cell therapy that's not often discussed that you wish people knew more about?
No, I think that we talked about the misconception, but the therapy itself, the idea that you can have one therapy programming your own cells to be fighters. And I tell patients it's like Miss Pac-Man. It's always going around in the bloodstream, eating away at the cancer cells. And so it's an ongoing therapy. They don't have to go to the infusion center every week or twice weekly. They still have to come and get monitored for their blood work. It's not a cure. It's just going to provide a longer period of remission off of treatment, which is very attractive. But some patients think that this is a cure. If I get a CAR T-cell therapy, somebody in Idaho hasn't had to have another treatment yet. And that could be you, but it might not be. And so really trying to provide quality education, and we have so many quality resources through ONS and from the ONS meetings. I think that that's really important. But from a nursing standpoint, as I mentioned before, I can't stress enough, if you're in a community center or a center that does not do CAR T-cell therapy, age is not a number, or not a number, age is a number. Age is only a number. There's really no cutoff, like unlike stem cell transplant, where there's general cutoffs in terms of organ function because you're using high doses of chemotherapy to wipe out the bone marrow. Cellular therapy, you don't do that for CAR T. So we have patients, and nurse navigators had also mentioned this. We have patients with advanced stage, advanced disease that still can have really nice outcomes. If you see somebody who's very, very sick and frail and coming in a wheelchair, is it the disease that's causing them to be so sick and frail? And if you take care of the disease, are they now going to be fit and functional? So we see that a lot in blood cancers and especially multiple myeloma. So no matter how sick patients are, they still should be considered for whatever therapy. And that shared decision-making discussion between the nurse, the patient, the provider, and the referring center, I think that that's all very valuable tools in order to arrive at a decision that's best for the patients and their caregivers.
That's a very excellent point. What did the focus group identify as some educational resources that nurses can use to educate patients?
So the leukemia lymphoma websites were good. ONS has great contact. The manufacturer websites we mentioned earlier, the barriers, as I cited before, were you can't necessarily print out and have materials in their institution, that branded materials, but you're still referring patients to those websites. So I think fortunately we have a lot of great websites for the myeloma patients. The International Myeloma Foundation and the MMRF are the two big myeloma foundations that have lots of resources as well. So fortunately, there are out there. And if they're at a CAR T-cell center, they're provided for them in the binders. So bring your binder everywhere.
Exactly. Beth, this has been excellent. Do you have any final comments for us?
Thank you so much for the opportunity to share the insights from the focus group. I do want to just underscore, as I did the last few minutes for the nurses that are listening, the focus group nurse navigators provided some rich insights and comments into the educational needs of our patients and really a window into what their day-to-day activities are with CAR T. And nurses are really well suited to counsel patients on these innovative therapies. We have lots of handouts through, again, the websites, the ONS, the manufacturers, the myeloma foundations, but give patients and caregivers the permission to seek an opinion from a large referral center. Sometimes they feel guilty leaving their community oncologist or they don't want to, but that infusion nurse in the community that's seeing that somebody's getting maybe a fourth line therapy, you say, hey, have you ever thought about going up to this city and seeing what they have to offer? Maybe there's a good clinical trial. Nurses are among the most trusted members of the healthcare team. We hear that over and over again. And it might be that infusion nurse, that bedside nurse that says, it's okay. And maybe that's all patients and caregivers need to hear from somebody. And it can be you as a nurse to provide those resources. And there's often a collaborative relationship to share patients, and they can get the best of both worlds. And that's what we all want, what is best for the patient.
Again, thank you so much, Beth, for joining us. And I look forward to hearing more from you and for hearing more about CAR T-cell therapy.
Excellent. Thank you.
Have a great day.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.